طلاب المرحلة الثالثة، السلام عليكم. ضمن CNS موديول محاضرة اليوم حنتناول الجزء الثاني من Cholinergic drugs cholinomimetics or acetylcholine agonists. The objectives of this lecture are to illustrate cholinereceptors, their classification, distribution, and mechanism of activation, pharmacokinetics and pharmacodynamics of direct and indirect cholinergic agonists, classification and pharmacologic actions of cholinergic drugs, clinical uses, adverse effects, and major contraindication of cholinomimetics, and also toxicity of direct and indirect cholinergic agonists. Acetylcholine is a widespread neurotransmitter in the body, mediating a broad range of physiological effects. It acts on two distinct classes of receptors or cholinereceptors, nicotinic receptors and muscarinic receptors. Muscarinic receptors is G protein coupled receptor, whereas nicotinic receptor is a ligand-gated ion channel receptor. Nicotinic receptors. Nicotinic receptors are cholinereceptors which are activated by the alkaloid nicotine. They constitute 5 subunits including 2-alpha, beta, gamma, and delta receptor subtypes. These receptors are located at myoneural junctions of somatic nerves and skeletal muscles, autonomic ganglia, adrenal medulla, and they are distributed at certain areas in the brain. These receptors are ligand-gated ion channels which mediate a fast signal transmission by the acetylcholine at the synapses. Binding of acetylcholine to the nicotinic receptors causes activation of these receptors, and this permits opening of ion channels in the cell membrane. This allows passage of sodium ions, which result in depolarization, and as a result there will be a propagation of the action potential. This is followed by a subsequent release of calcium ions from the sarcoplasmic reticulum to produce muscular contraction. Hydrolysis or degradation of this neurotransmitter will produce choline and acetate, and this occurs usually by action of the enzyme acetylcholine esterase, which result in depolarization of the muscle cell. Muscarinic receptors or cholinereceptors. These receptors are activated by the alkaloid muscarine. They are localized on numerous autonomic effector cells including cardiac atrial muscle and cell of the sinoatrial and atrioventricular nodes, smooth muscles, exocrine glands, vascular endothelium, mostly the arterioles, and certain areas in the brain. Muscarinic receptors are classified into 3 main receptor subtypes, including M1, M2, and M3 receptors. M1 receptors are distributed in sympathetic postganglionic neurons in the central nervous system, and also they are found in gastric parietal cells. M2 receptors are located in cardiac and smooth muscle, whereas M3 cholinereceptors are found in glandular cells, example gastric parietal cells, and vascular endothelium, and also vascular smooth muscle. In addition to these three types of cholinereceptors, two further subtypes are identified, including M4 and M5, but still no functional action has been identified for these two receptor subtypes. Cholinergic agonists act on M3 muscarinic receptors of endothelial cells, will promote the release of nitric oxide. Nitric oxide will diffuse to the vascular smooth muscle and therefore it will produce relaxation. It means it will result in vasodilation of blood vessels. Interaction of the neurotransmitter acetylcholine with M1 and M3 muscarinic receptors stimulate hydrolysis of phosphatidyl inositol biphosphate into inositol triphosphate or IP3 and diacylglycerol or DAG. This results in the influx of intracellular calcium ions, which result in contraction of smooth muscles. Phosphatidyl inositol is phosphorylated twice to form phosphatidyl inositol biphosphate. The activated receptors on the cell membrane are coupled through the G protein to phospholipase C, and this enzyme will cause hydrolysis of phosphatidyl biphosphate to generate inositol triphosphate or IP3 and also diacylglycerol, which remains on the cell membrane. And this will stimulate protein kinase C enzyme to initiate protein phosphorylation, whereas IP3 or inositol triphosphate activates calcium signaling by binding to calcium channels on the intracellular organelles that usually store calcium ions, such as endoplasmic reticulum. Cholinergic drugs, cholinomimetics or acetylcholine agonists. These drugs act on postsynaptic acetylcholine receptors or cholinereceptors at all sites in the body, where the acetylcholine is the effective neurotransmitter. So they mimic the action of acetylcholine at all sites. Cholinergic drugs are generally classified into direct-acting receptor agonists and indirect-acting or cholinesterase inhibitors or anticholinesterases. For the direct-acting receptor agonists, they are also subdivided into two types, cholinesters and alkaloids. Cholinesters, example, carbachol and bethanychol, they act at all sites like acetylcholine. They are resistant to degradation by cholinesterase. Muscarinic effects of these agonists are much more prominent than nicotinic effects. Second subtype of direct-acting receptor agonists include alkaloids. Example, pilocarpine and muscarine. These agonists act selectively on end organs of postganglionic cholinergic neurons. Second type of cholinergic drugs is the indirect acting cholinesterase inhibitors or anticholinesterases, such as physostigmine, neostigmine, pyridostigmine, distigmine, rivastigmine, and donepezil. These drugs inhibit the enzyme that cause degradation of acetylcholine, which is the acetylcholinesterase. And the acetylcholine as a result will persist and increased at both muscarinic and nicotinic cholineceptors to produce its pharmacologic action. Direct-acting cholineceptor agonists. Pharmacokinetics. Choline esters are poorly absorbed and poorly distributed into the central nervous system. This occurs because they are hydrophilic, although they are hydrolyzed in the gastrointestinal tract, and they are less effective by oral routes. They differ markedly in their susceptibility to hydrolysis by choline esterase. فإذا عندنا choline esters are poorly absorbed and poorly distributed into the CNS. This occurs because they are hydrophilic, and usually they are hydrolyzed in the GIT, therefore they are less effective by oral route. Large amounts must be infused intravenously to achieve concentrations sufficient to produce detectable effects. A large intravenous injection has a brief effect or a short duration of action, typically for 5 to 20 seconds, whereas intramuscular and subcutaneous injections produce only local effects. The tertiary natural cholinomimetic alkaloids, such as pilocarpine, nicotine, and lobeline, are well absorbed from most sites of administration. Pharmacodynamic. Several cellular events occurs when muscarinic receptors are activated. All muscarinic receptors are G-protein coupled receptors. Muscarinic agonist binding to M1 and M3, M5 receptors activate the inositol triphosphate or IP3 and diacylglycerol cascade. Diacylglycerol is involved in opening of smooth muscle calcium channels. IP3 releases calcium ions from endoplasmic and sarcoplasmic reticulum. Muscarinic agonists also increase cellular cyclic GMP concentrations. Activation of muscarinic receptors also increase potassium flux across cardiac cell membranes and decrease its concentration in the ganglion and smooth muscle cells. Activation of M2 and M4 muscarinic cholineceptors inhibit the enzyme adenylyl cyclase activity in tissues. Muscarinic agonists reduce activation of this enzyme adenylyl cyclase and modulate the increase in cyclic AMP induced by hormones such as catecholamines. The nicotinic receptor has two agonist binding sites. Agonist binding to these receptor sites causes a conformational change in the protein and cause channel opening, which allows sodium and potassium ions to diffuse rapidly down their concentration gradients. Calcium ions may also carry charge through the nicotinic receptor ion channel. Binding of agonist molecule to one of these two receptor sites will moderately increase the probability of channel opening, whereas binding of the agonist to both of these receptor sites will greatly enhance opening probability. Prolonged agonist occupancy of the nicotinic receptor will abolish or decrease the effector response in the postganglionic and the postganglionic neuron stops firing. Skeletal muscle relax. Furthermore, the continued presence of nicotinic agonists prevent electrical recovery of the postjunctional membrane. Thus, a state of depolarization blockade occurs initially during a persistent agonist occupancy of these receptors. Indirect acting cholinereceptor agonists. Pharmacokinetics. There are three chemical groups of cholinesterase inhibitors, including simple alcohols bearing a quaternary ammonium group, example idorphonium. The second type, carbamic acid esters of alcohols having quaternary or tertiary ammonium groups, such as carbamates, example neostigmine. The third group include organic derivatives of phosphoric acid, example organophosphorates, such as eicosapentaene. Absorption of quaternary carbamates from the conjunctiva, skin, GIT, and lungs is predictably poor, since their permanent charge makes them relatively insoluble in lipids. Thus, much larger doses are required for oral administration than for parenteral injection. Distribution into the central nervous system is negligible. Physostigmine, in contrast, is well absorbed from all sites and can be used topically in the eye. The organophosphate cholinesterase inhibitors, except for eicosapentaene, are well absorbed from the skin, lungs, gut, and conjunctiva. Therefore, they are dangerous for humans and highly effective as insecticides. They are relatively less stable than carbamates when dissolved in water. Thus, they have a limited or a short half-life. All the cholinesterase inhibitors increase the concentration of acetylcholine at cholinereceptors by inhibiting the cholinesterase enzyme. The first group, of which idorphonium is the example, consists of quaternary alcohols. These agents reversibly bind electrostatically by hydrogen bonds to the active sites of the enzyme, thus preventing excess of acetylcholine. The enzyme inhibitor complex will not involve a covalent bond and is correspondingly short-lived for 2 to 10 minutes. The second group consists of carbamate esters, example neostigmine and physostigmine. These agents undergo a two-step hydrolysis sequence similar to that process which occurs for acetylcholine. The covalent bond of the carbamated enzyme is considerably more resistant to the second hydration process, and this step is correspondingly prolonged. It occurs for 30 minutes to 6 hours. The third group consists of organophosphates. These agents also undergo initial binding and hydrolysis by the enzyme acetylcholine esterase, resulting in a phosphorylated active site. The covalent phosphorus enzyme bond is extremely stable, and hydrolysis in water occurs at a very slow rate, hundreds of hours, after the initial binding hydrolysis step. ralidoxime is capable of reactivating the inhibited acetylcholine esterase. However, it is unable to penetrate into the CNS. As a result, this drug is not useful in treating the CNS effects of organophosphates. Organophosphate inhibitors are sometimes referred to as irreversible choline esterase inhibitors, whereas hydrophonium and carbamates are considered as reversible inhibitors because of the marked differences in their duration of action. This table shows the therapeutic uses and duration of action of choline esterase inhibitors. For example, for hydrophonium, it is used in myasthenia gravis, ileus, and arrhythmias, and its duration of action is 5 to 15 minutes. For the carbamates and related agents, neostigmine is used usually in myasthenia gravis and ileus, and its duration of action ranges from 0.5 to 4 hours. Pyridostigmine, used mainly in myasthenia gravis, its duration of action is 4 to 6 hours, and physostigmine is used for anticholinergic poisoning, and its duration of action is usually ranges between 0.5 to 2 hours. For the organophosphates, ecothiopate is used mainly in glaucoma, and it has a long duration of action, about 100 hours. Actions of cholinergic drugs on the eye. Cholinergic drugs produce spasm of the circular smooth muscle fiber of the ciliary muscle. Therefore, it produces accommodation for near vision. Cholinergic drugs also produce contraction of smooth muscle of the iris sphincter, and therefore to produce miosis. They also cause a reduction in the intraocular pressure due to an increased outflow of aqueous humor into the canal of Schlemm. Their effect on cardiovascular system, they produce a negative chronotropic effect or a reduced SA node activity. They cause decreased conduction velocity through the AV node. These drugs have no effect on the force of contraction, and this usually because no muscarinic receptors are found on the ventricles. They produce vasodilation mainly of the arterioles and capillaries, and this effect occurs because of the action of these drugs on the endothelial cell to promote release of the nitric oxide. The nitric oxide diffuses to the vascular smooth muscle and produce relaxation or vasodilation, therefore resulting in a decrease in blood pressure and a reflex increase in heart rate. On the gastrointestinal tract, they produce increased smooth muscle contractions and tone, and also they cause increased peristaltic activity and motility. These drugs increase salivation and acid secretion, and tone in sphincters will decrease, and this will promote defecation, which occur because of relaxation of the anal sphincter, and also they cause acid reflux or regurgitation, and this occurs because of esophageal sphincter relaxation. On the urinary tract, these agents cause increased contraction of the ureter and the bladder smooth muscle with relaxation of the sphincter. Therefore, these drugs promote micturition. On the respiratory tract, they produce bronchoconstriction with increased bronchial secretions. Therefore, patient with asthma, cholinergic drugs should be avoided. This table shows summary of the main actions of some cholinergic agonists. Bethanycol is used mainly in the treatment of urinary retention. Carbachol produces miosis during ocular surgery. Usually it is used topically to reduce the intraocular pressure in open-angle glaucoma or narrow-angle glaucoma, particularly in patients who have become tolerant to pilocarpine. Pilocarpine reduces intraocular pressure in open-angle and narrow-angle glaucoma. It binds preferentially at muscarinic receptors. Pilocarpine can penetrate the CNS. Physostigmine, it increases intestinal and bladder motility. It can reverse CNS and cardiac effects of tricyclic antidepressant, and it reverses CNS effect of atropine. Also, it can penetrate into the CNS. Neostigmine is used mainly to prevent post-operative abdominal distension and urinary retention. It is also used in the treatment of myasthenia gravis, and it can be used as antidote for competitive neuromuscular blockers. It has intermediate duration of action, about 0.5 to 2 hours. Hydrophonium usually is used for the diagnosis of myasthenia gravis. It has a very short duration of action, about 10 to 20 minutes, and it can be used as antidote for competitive neuromuscular blockers. Rivastigmine and donepezil is used as a first-line treatment for Alzheimer's disease. Ecothiopate is used in treatment of open-angle glaucoma. It has, as we said previously, a long duration of action, about 100 hours. And acetylcholine can be used to produce miosis in ophthalmic surgery. Other effects: these drugs increase the secretion of tears from lacrimal gland, and also they increase sweat gland secretions. These drugs produce tremor and ataxia. Ataxia is usually caused by damage to the cerebellum, but it also can be caused by damage to the spinal cord or other nerves. In drug overdose, mental excitement occurs with confusion, restlessness, insomnia, with nightmares, and sometimes even convulsion and coma. Main uses of cholinergic drugs: they are used for the diagnosis and treatment of myasthenia gravis. For the diagnosis of this condition, hydrophonium is usually used. As we said, it has a short duration of action, which is about 5 to 15 minutes. And for the treatment of this condition, neostigmine, pyridostigmine, and distigmine can be used. Other use of cholinergic drugs: they are used to stimulate the smooth muscle activity of the bladder. So they are used to prevent urine retention, and also they can be used to stimulate the bowel after surgery for post-operative abdominal distension and for gastric atony, but without the presence of obstruction. For example, bethanycol, carbachol, and distigmine can be used. Bethanycol has a longer duration of action than acetylcholine, which is about 2 to 3 hours. It can be administered either orally or subcutaneously, but not intravenously or intramuscularly, because parenteral administration of this drug may cause cardiac arrest. Cholinergic drugs can be used to lower intraocular pressure in chronic simple glaucoma or open-angle glaucoma. For example, pilocarpine, it can be topically administered, and carbachol is used when pilocarpine is ineffective. Also, they are used for cobra bite. Cobra venom has a curare-like neurotoxin. Although specific anti-venom serum is the primary treatment, but neostigmine and atropine can be used to prevent respiratory paralysis. They are used in belladonna poisoning. Physostigmine is used in a dose of 0.5 to 2 mg intravenously and can be repeated as required. For this poisoning, it can penetrate the blood-brain barrier and antagonizes both central and peripheral actions. However, physostigmine induces hypotension and arrhythmia, but it can be employed as a last choice. In this condition, neostigmine does not block the central effect, but it is less risky. These cholinergic agonists can be used for other drug overdosages. For example, in case of tricyclic antidepressant, phenothiazines, and many antihistamines which have additional anticholinergic property. Also, they can be used in Alzheimer's disease, which is a neurodegenerative disorder affecting cholinergic neurons in the brain. The relatively cerebroselective anticholinesterase tacrine, rivastigmine, donepezil have been used to improve cognitive function in these patients. Pilocarpine is used for surgery in acute narrow-angle glaucoma, which is a medical emergency. Pilocarpine is often given in combination with indirectly acting muscarinic agonists such as physostigmine. In glaucoma, there is improper drainage of the watery fluid inside the eye, which is known as the aqueous humor. Two pathways are identified for the drainage of this fluid, or the intraocular fluid, including the trabecular meshwork and the uveoscleral outflow. In glaucoma, the angle refers to the angle between the iris and the cornea. So, in open-angle glaucoma, the uveoscleral drainage canals are clear, but the trabecular meshwork is blocked. Therefore, this will cause the pressure will build up inside the eye gradually or chronically. While in closed-angle glaucoma, both pathways are blocked. The uveoscleral drain and the trabecular meshwork. Therefore, there will be an acute increase in the intraocular pressure inside the eye, and this might progress to optic nerve damage and even visual loss. They can also be used for bronchial hypersensitivity and also in asthmatic conditions. For example, methacholine can be used in this condition. These agonists can be used to treat Sjogren's syndrome, which is a disorder of the immune system manifested by two important symptoms, including dry eyes and dry mouth. Pilocarpine and civimelline is a neuromuscarinic receptor agonist, are used to increase both salivary and secretion of tears from the lacrimal glands. Anticholinesterase poisoning. Anticholinesterase are easily available, and they are extensively used in agricultural and household insecticides. Accidental as well as suicidal and homicidal poisoning is usually common. Local muscarinic manifestations at all sites of exposure, such as skin, eye, and GIT, occur immediately, and these are usually followed by complex systemic effects, including irritation of the eye, lacrimation, salivation, excessive sweating, copious tracheobronchial secretions, meiosis, blurred vision, breathlessness or dyspnea, colic, and involuntary defecation and urination. Also, there is a fall in blood pressure with bradycardia or tachycardia and cardiac arrhythmias with vascular collapse. Muscular fasciculations, weakness, respiratory paralysis, and also excitement, tremor, ataxia, convulsions, coma, and even it might end with death. Death is generally due to respiratory failure. Toxicity with direct-acting muscarinic stimulants. Drugs such as pilocarpine and choline esters cause signs of muscarinic excess when given in overdoses. These effects include nausea, vomiting, diarrhea, urinary urgency, salivation, excessive sweating, cutaneous vasodilation, and bronchial constriction. All these effects are usually blocked competitively by administration of atropine. Certain mushrooms contain muscarinic alkaloids. Ingestion of these mushrooms causes typical signs of muscarinic excess within a period of 15 to 30 minutes. These effects can be very uncomfortable, but and rarely they are fatal. Treatment is usually with administration of atropine in a dose of 1 to 2 mg parenterally. Second, direct-acting nicotinic stimulants. Nicotine itself is the only common cause of this type of poisoning. Nicotine was used in insecticide and now has been replaced by nicotinoids, which is a synthetic compound that resembles nicotine only partially in structure. Nicotinoids are more toxic for insects more than for vertebrates. Acute nicotine toxicity. A fatal dose of nicotine is approximately 40 mg or 1 drop of pure liquid. This is the amount of nicotine which is found in 2 regular cigarettes. Fortunately, most of the nicotine in cigarettes is destroyed by burning or escape via side stream smoke. Ingestion of nicotine, insecticide, or of tobacco by infants and children is usually followed by vomiting, and this will limit the amount of alkaloid absorbed. Toxic effects of a large dose of nicotine are simple extension of their previously described actions. The most dangerous effects include central stimulant action. They may cause convulsions and even this may progress to coma and respiratory arrest. Skeletal muscle end-plate depolarization, and this may leads to depolarization blockade and may end up with respiratory paralysis and also hypertension and even cardiac arrhythmias. Treatment of acute nicotine poisoning is largely symptom-directed or symptomatic. Muscarinic excess resulting from parasympathetic ganglion stimulation can be controlled by administration of atropine. Central stimulation is usually treated with parenteral administration of convulsants such as diazepam, and neuromuscular blockade is usually not responding to pharmacologic treatment, and it may require mechanical ventilation. Fortunately, nicotine is metabolized and excreted rapidly. Patients who survive for the first 4 hours usually recover completely if hypoxia does not occur, or even brain damage. Chronic nicotine toxicity. The addictive power of cigarette is usually caused by their nicotine content, and it is highly probable that nicotine contributes to the increased risk of vascular diseases and sudden coronary death, which is associated with excessive smoking. In addition, nicotine contributes to the high incidence of ulcer recurrence in smokers with peptic ulcer. An effective agent which is used for smoking cessation is varenicline, which is a synthetic drug with partial agonist action at nicotinic receptors. This drug also has antagonist properties, which persist because of its long half-life and its high affinity for receptors. And this will prevent the stimulant effect of nicotine at presynaptic nicotinic receptors, and as a result, this effect will cause release of dopamine. The use of this agent is limited because of its ability to cause nausea, insomnia, and exacerbation of psychiatric illnesses, including anxiety and depression. Cholinesterase inhibitors. The acute toxic effect of cholinesterase inhibitors are usually direct extensions of their pharmacologic actions. In acute intoxication with these agents, the patient should be treated immediately, especially in patients with heavy exposure. The dominant initial signs of these intoxications include miosis, salivation, sweating, bronchial constriction, vomiting, and diarrhea. Central nervous system involvement may cause cognitive disturbances, convulsions, and even coma. Treatment of this condition includes maintenance of vital signs, especially respiration, decontamination to prevent further absorption, and atropine should be administered parenterally in a large dose, and it can be given as required, and it can be repeated to control signs of muscarinic excess. Also, therapy includes treatment with pralidoxime and the administration of benzodiazepines for seizures. Chronic exposure to certain organophosphate compounds, including some organophosphate cholinesterase inhibitors, may cause delayed neuropathy, which is associated with demyelination of axons. And these effects are not caused by cholinesterase inhibition, but rather by inhibition of neuropathy target esterase. These symptoms, which include weakness of upper and lower extremities and unsteady gait, usually appears within 1 to 2 weeks after exposure. There is another nerve toxicity condition called intermediate syndrome, which occurs within 1 to 4 days after exposure. And this syndrome is characterized by muscle weakness, and its origin is not known, but it may appear to be related to cholinesterase inhibition. Main adverse effects of adrenergic agonist. The most common adverse effects include GIT symptoms, including nausea, vomiting, abdominal cramps, and diarrhea, miosis, excessive sweating and salivation, bronchoconstriction, and increased mucosal secretions. Also, they produce hypotension, cardiovascular collapse, and respiratory failure. All these adverse effects, can be blocked or reversed by the use of atropine. Treatment with atropine, which include administration of atropine in a dose of 2 mg intravenously, and this can be repeated every 15 to 60 minutes. Also, it will include maintenance of respiration. Diazepam should be given for the treatment of convulsions, and parenteral administration of pyridoxine to activate the acetylcholinesterase enzyme, and it should be administered in a dose of 1 to 4 grams hourly intramuscularly or by slow intravenous infusion. Systemic effects are minimal for drugs which are applied topically into the eye. The main contraindications of cholinergic agonists. Peptic ulcers, because they increase gastric acid secretions in asthmatic patient, cardiac diseases, Parkinson's disease, hyperthyroidism, because they predispose to arrhythmia, and also they are contraindicated in the presence of mechanical obstruction of the gastrointestinal or urinary tract. At the end of this lecture, a summary: acetylcholine is a widespread neurotransmitter which acts on two main distinct classes or cholineceptors, nicotinic receptors and muscarinic receptors. Cholinergic drugs or cholinomimetics are classified into two main types: direct-acting cholinergic agonist and indirect-acting cholinesterase inhibitors or anticholinesterases. For the direct-acting receptor agonist, they are further subdivided into two main subtypes: cholinesters and alkaloids. And as we said, cholinesters include examples such as carbachol and bethanychol. They mimic in their action the acetylcholine, and they have a predominant muscarinic effect more than their nicotinic effects. Alkaloids such as pilocarpine and muscarine, they act selectively on the end organs of postganglionic cholinergic neurons. The second type is the indirect-acting cholinesterase inhibitors or anticholinesterases, including physostigmine, neostigmine, pyridostigmine, distigmine, rivastigmine, and donepezil. These drugs inhibit the enzyme acetylcholinesterase, which destroys or causes degradation of the neurotransmitter acetylcholine, and this allows the acetylcholine to persist and increases at both muscarinic and nicotinic cholineceptors. At the end of our lecture, thank you for your listening.